Have at it.
Yeah.
Hi, this is Leah.
So you booked.
So good afternoon, everybody. Thank you for joining us. This is Leah Baza from the PPOC. I'm over in the Brookline office. We do actually have a couple attendees remote today, Daniel Viens and Megan Kelly, both of whom are on our ACO team at Chico. And so they will also be providing us some information regarding our transition into the ACO. The point of today's webinar is just to talk through the different issues that we see with the transition to the ACO and talk through some solutions for that. I don't expect that this will be our last webinar related to your January launch. This is more of an overall view of what we've seen happen in the past and what we expect the process to look like. And so for those of you who are not familiar with Zoom, you are able to unmute yourself if needed, if you'd like to ask questions, or you can use the chat feature. And so with that said, I'll go ahead and get started. As you can see, we have a pretty full agenda here, so I'm going to just go ahead and kick right into it. What I'll do after the presentation is I'll actually send you a copy of this presentation so that way you can reference it later on if needed. So for roster management, what does that mean? Basically, we need to try to ensure that all of your current Medicaid patients are identified and moved into the Tough Together Boston Children's ACO for January 1st. And how do we do that? On the ACO side, there are some actions that they'll take. They will provide your practice with a list of patients that have been identified by Mass Health to be moved to the ACO on January 1st. And so what that means is that you'll get a list of patients. You actually do not have to do anything with that list if you choose not to. It really depends on what your intention will be with that. If we can get a list of your current roster from your existing Medicaid panel, that would be really helpful. We can actually take that list and try to match it up against Mass Health list. And then when we give it to you, we can call attention to anybody that's missing. So for instance, if Mass Health has a subset of patients that are identified as belonging to you and you don't actually have those patients on your roster, we'll be able to draw attention to that. And alternately, if you are identifying patients that you think are actively in Medicaid today, but Mass Health doesn't have them scheduled to be moved over, we'd like to be able to know that. Now, with that said, you're not required to do any work on it, and depending on the volume, we may not be able to do any large-scale resolutions. So it might be a more manual process, reaching out to patients, trying to figure out, checking their eligibility. We do see a lot of churn in the Medicaid population, so it's possible that your EMR has them listed in Medicaid, but they've actually lost eligibility or they're on a commercial plan. So for those of you on the call, if you can get a roster from your existing Medicaid payer and provide it to us, that information will be really helpful for us, and we can try to do some work with that and match it up against what Mass Health says. Anybody have any questions about the roster management process?
Hi, Leah. This is Dan at Chico. I just want to chime in for 1 second.
Right, thank you.
Yeah. So just to reiterate, I think when the state pulls the list of your roster of who they're going to transition to the BCH ACO, that roster comes from a single point in time, and they're in the process of doing that as we speak. So when you get that roster, say you get it to look at it in mid or late October, it will already be incorrect, and I'm using air quotes you can't see, to some degree, because it's, you know, a month old of data. And by the time your patients actually get switched in January, it'll be 3 months old. And that's sort of just the issue with like prospectively enrolling people into a new plan, is that as Leah said, these things are fluid. So based on this process from last year, we know the state will look at everybody who transitions on January 1st. It'll sort of see what the gap is. Who are all those people who moved around between plans over the course of, say, September, October, November, December, et cetera. And then they'll make sort of a second shift of people probably in late January, early February, of people who may have been moved since they drew that line in the sand, you know, right now, early this fall. So to Leah's bigger point, we don't have a specific action for you to take when you get that roster or you see that roster. It's more of an FYI and a way for us to identify any huge issues. I don't think we'll find any huge issues, but it's a starting place, and we know there'll be things that need to be done later on to sort of clean it up, whether that's patients having to call Mass Health and request to be moved, or if it's actually Mass Health taking action to move another subset of patients at a later date. So I think that's just one more piece of narrative on that.
Great, thank you, Dan. Okay, if there's no questions about roster management, I'll move right on. Oh, it looks like we might have a question. When would you like us to send our roster in? The sooner you can get that to us, the better. If you need a secure email, I can send you one where you can reply to it and send it securely. Again, the work that can be done with that is really just to match it up and draw our attention to the Mass Health list and where there may be discrepancies. So if you have access to it now and you want to send it over, I'm happy to take that. If you don't have my contact information, let me know, but I'm pretty sure that you probably do. Okay, PCP attribution. Okay, I will send out a secure email. Thank you for that. The PCP attribution. So what we've done at this point is we have provided a list of your PCPs to Mass Health and Tufts to ensure that they are correctly attributed to our ACO. So what we need to keep clear is that the member assignment to the ACO is done at the Mass Health level. So a lot of times practices get confused about Tufts assigning patients into the wrong plan. Plan selection is not done at the Tufts level. That is actually done at the Mass Health level. The Tufts themselves will assign PCPs. One thing that I will tell you that it really makes things easier when we do this transition is if you have providers that have closed panels, it's really helpful to open those panels before we do this process, because if patients are incorrectly attributed to the wrong PCP, which is very possible, it makes it more challenging to update the PCP. So if you know that you have providers that have closed panels, it's best that we try to make sure those are open, at least initially, while we're trying to do this transition. The thing I wanted to mention about the PCP attribution, all of you out there in the practices know that there's challenges with PCPs and Mass Health. The easiest way to update a patient's PCP at any time is through the Tufts Provider Connect portal. I actually have a screenshot of a manual that I'll send out to you that shows you how to do it if you don't know how to do it already. So with that said, there's other ways to do it. Patients can actually call Tufts and request that their PCP get changed. And I believe practices at times can call to change PCPs, but the preferred method is to do it online via Provider Connect. So for you, because you're just joining the PPOC, there will be a form that I have you sign when I come and do your onboarding. So for the practice I've already onboarded with, you've already gotten the form, and that form will allow you to set up administrators in Tufts Provider Connect that you can add and change users, and that will assign you to the PPOC. So for Woburn, I'm coming out to you next week and I'll bring that form to you. It's not anything that we have to do today, but we should definitely do it before the end of the year. So any questions about PCP attribution? Great. So EMR updates, depending on your volume of patients and what plans they're in now, it's possible that you'll have a pretty significant amount of patients whose EMRs need to be updated. We may possibly have resources to assist with that if you let us know that you need it. So I can't guarantee that, but if you feel like Woburn or Brockton that it would be useful to have a resource to assist you with updating your patient's EMR before the ACO launches, you can let us know. Dan can speak to a little bit about what that might consist of. And then in terms of Falmouth, because Falmouth is going live on Epic prior to the launch, it's possible that our Epic team can update their insurance for them automatically on December 31st. So when they arrive on January 1st, the ACO becomes available as a suggested coverage.
Yeah, so just this is Dan once again at Chico. Historically, what we've done in this case for practices who need assistance is that we may be able to obtain some temporary staffing for you to get trained up on your EMR and actually sit down and go through and manually update the insurance and ID numbers of the 1,800, 2,500 members that your practices have. If you don't have a digital way to sort of batch update members as we would be able to do for practices already on Epic. So that's just sort of really high level, the type of extra help it would be. The exact scenario just depends on the practice and the nature of the EMR and what it takes to do it. But the first step is just to certainly raise your hand, and then we can start working with Leah and Megan and our team here to figure out what set of resources would be the most helpful and what the timeline is to get that off the ground. So take some time to discuss internally and let Leah know, and we'll get the ball rolling on our end to see what we can do to help.
Thank you, Dan. Okay. The other thing that I wanted to touch on is that because you've been in an ACO already, but when you signed up for the ACO, you became exclusive as a PCP for your ACO. So when you join the PPOC come January 1st, you will exclusively be a PCP for Tufts Together Boston Children's ACO. Most patients, the vast majority of MassHealth members, will need to enroll into the ACO, and that is if they have MassHealth Standard, if they have Common Health, Care Plus, or even Family Assistance. So typically when you run your MassHealth eligibility, you might see Family Assistance, and when you drill into that, if they are in any ACO or MCO, it needs to be ours. Now, with that said, there are some other members that will not need to enroll in our ACO, and in some cases they can if they choose to, but they do not need to. So specifically, patients that are in DCF custody are not required to move into an ACO or an MCO for convenience purposes in case they're moving homes and things like that. With that said, DCF has verbalized to us that they're trying to, when possible, keep kids with the PCP that they have, and in those cases, they will in fact be enrolling them into the ACO. When you run a patient's eligibility in the EVS system, the MassHealth eligibility system, you will see underneath the MassHealth Standards section refer to social worker, and that's usually your indication that DCF is involved, just for those of you who aren't aware of that. Patients that have MassHealth Limited, Children's Medical Security Plan, Health Safety Net, or MassHealth as a secondary do not need to enroll into the ACO. So those are limited plans, and they're not typically eligible for full ACO or MCO benefits. And so you can continue to see those patients because you're contracted with MassHealth. And then the final note that I wanted to make is that there is a small subset of members that are enrolled into a program through Boston Medical Center called Special Kids Special Care. These patients are actually in DCF custody, and they have complex medical needs. If your practice is identified as having any patients that fall into this category, BMC will notify me, and I will reach out to you to make sure that the contracting is all set. So any questions about ACO or not? Great. One thing I recommend is maybe printing out this slide and giving it to your receptionist or secretaries, people that are looking at eligibility and may need to know who does or doesn't have to be into the ACO. So you probably know that part of the goal of this ACO launch was for patients to be in one plan, similar to the way that your commercial patients will be locked into a plan. So what that means is that patients will, after their 90-day period, they will be in something called fixed enrollment. When they're in fixed enrollment, they should not be able to change health plans until their next plan selection period. Which is typically a year later. So if they join the ACO in January, they have open enrollment through March, the following January would be their open enrollment period again. With that said, there are some built-in exceptions. for obvious reasons. If they move out of the service area of their existing ACO or MCO, then they can change plans. If there's issues with service, if they're not being able to receive services that they would need in their existing plan, then they will give them an exclusion for that. If the patient is homeless, they can change their plan. It just has to be documented at Mass Health. So Mass Health has to have something in the records that indicate that the patient is homeless. And then we were able to negotiate that when it comes time to transition patients to an adult PCP, they will then be able to change their plan, even if it's outside of their annual open enrollment period. I wanted to make note that, again, the following members are able to change their health plans at any time if they're in custody of DCF, if they're in the custody of DYS, if they're newborns or babies under 1 year old, they do not get into a locked enrollment period. And then members who enroll into the PCC plan are not locked in. They can change their plan anytime. Of course, if they move out of the PCC plan into an ACO or an MCO, then at that point they would be locked into that plan. But the PCC plan itself, they do not get locked into. Really, really important to take special note about the newborns and the babies are able to change their plan for that first year for any reason. Any questions about fixed enrollment? I will say that in my experience, Mass Health has been fairly flexible with this, and patients have been able to move plans, especially if they were wrongly assigned to begin with. And say, for instance, they're not assigned into our ACO in January and their open enrollment closes in March, but they're college age and you don't see them until June, there is the option to request exceptions to this fixed enrollment policy. Dan, do you have anything on that, or you think I covered that?
No, that's perfect. I would just say as a general sort of piece of information over the top of it, the intention is for patients to be pretty stable where they are, but I would say in the first 18 months of the ACO environment, and you all know this since you're coming from an ACO, patients have really been able to move around at will, and they've been pretty liberal with those exceptions. So, you know, while they want people to stay pretty much where they are, at the end of the day, as people are still figuring out how this is all working, they're letting people move around and get with the providers they need to be with. So we're not too concerned about getting people into the right plan as a general rule. And as soon as things start locking up more firmly than that, we'll definitely be sending out communication so that people can be prepared.
Okay, thank you. Okay, so network access, depending on where the majority of your patients are coming from, we've already had the geography for the practices that are joining the ACO, so we should have a pretty consistent network near you. The best way to find out if one of your specialists that you're referring patients to is in network is to go to the Tufts Health Plan Provider Search tool. Once you get in there, you can drop it down to the Tufts Boston Children ACO, put in the name of the provider, and it will tell you if they're in network or not. With that said, we asked you earlier this year for a list of your most commonly referred to specialists, and we provided that to Tufts, and we're not aware of any large gaps in those coverages. If we become aware of any, obviously we'll let you know. If you do have providers that you work with and they're not in network, you know, there's a couple things you could do. It's obviously preferred that you try to find an in-network alternative. The other thing that you can do is you can encourage that provider to join the network. So on this slide is a link for providers who are not currently contracted with Tufts to try to go ahead and get them contracted. The one area that I see some room for that is a lot of behavioral health. So if you have some behavioral health folks that you're referring to and they're out of network, as a primary care physician or a practice, if you can encourage them to join the network, then we will work to try to get them in the network as soon as possible. If you're really having a lot of troubles with network access, you'll see at the bottom that there is an email that you can send information into, and then the ACO team will try to help you to resolve the network access issue. Okay, so this is a very small piece of the ACO finances, but I just wanted to draw our attention to, as you know, pre-ACO, practices had multiple payers. They could have been fee-for-service, PCC, Neighborhood Health Plan, Tufts, Health New England. All of those providers were on different fee schedules. As of March of 2018, for us at the PPOC, Tufts Public is our only ACO payer. Those rates are paid at standard rates, Mass Health standard rates. Many of you know that the Mass Health standard rates were a lot less than the previous MCO and ACO, well, MCO rates through the state. So in order to try to help make up for that, part of the payment for PCPs is a value-based payment. So that's up to 10% of fee-for-service revenue that you could potentially earn if we meet quality measures. The one thing to keep in mind with all of this is that as a whole, PPOC swims and flies and swims together. So this is based on network. It's not your individual practice. So the whole network has to be successful for anybody to be eligible for these value-based payments. The other payment that you'll expect to start getting will be infrastructure payments. So per member per month, and that is $8.39 per your attributed Mass Health patients. That's not based on performance. We send those checks out once a month. So that's how you can expect your payment for the ACO to work. Great. One thing to keep in mind with our ACO is that we do not require referrals for our ACO. So if your member, if your patient needs to see a specialist in another network or in our Boston Children's Network, you don't need to provide a referral for that. What that also means is that if there is a PCP attribution problem, if you have a patient that's in our ACO and should be yours, but is actually listed under another PCP in the ACO, you won't have claims issues on that because there's no referral needed, so it shouldn't stop the claim from paying. I still recommend that you log into Health Trio and try to update the PCP, but at least you know that if somebody presents for a visit same day and they have the wrong PCP, you shouldn't have claims issues around that. So this is a good visual for your staff, whoever's doing your referrals, to know that you won't need to process referrals for in-network Tufts providers. So cross coverage, I don't imagine that you have any partners that you cross coverage with. Falmouth may, just based on the sizes of the practices, but if you do have other practices that you cross cover with, say for instance, you're part of a cross coverage group where every Saturday your patients go down the street to a non-PPOC practice. If that's the case with your practice, I need you to let me know so that way I can notify Tufts and they can set them up so their claims can process. Other ACOs, if the practice is in another ACO, including partners or steward, and you're seeing their patients, they will require Mass Health referrals. So you will need to work with your cross-covering partner, that practice, to make sure that whatever the requirements are from that other system for you to get paid, that you're doing that. On the Tufts side, for your cross-covering partners, we can help to get them set up so claims process. If you do have any of those type of relationships, definitely reach out to me and let me know so I can work on getting that started before January. Okay. Dan, do you want to talk about newborns for me? I have this one and then the future state of newborns.
Yeah, happy to. So, newborn enrollment in the Mass Health has always been a little bit of a challenging subject. So, the notice of birth form is something that is done by the hospital where the child is born. They have up to 30 days to send that into the state. They're generally all pretty good about doing it sooner. That is actually what triggers the baby's eligibility and ultimately their enrollment into a plan. The current system assigns the child to the mom's plan. Now, in the case of the BCH ACO, we're almost never the mom's plan. So that creates a little bit of an issue where, that child is then going to need to get moved again after they get auto-assigned into the mom's plan in order to be in the correct ACO for BCH. So I think that's a little bit of just like a FYI heads up that as you have new babies coming to your clinic, and they may be auto-assigned, you'll see them on whether it's NEQA or Steward or Partners, whatever. This will be something a little bit different for all of you because the ACOs you are coming on for probably, weren't strictly pediatrics as ours is. So it probably wasn't as much of an issue as it might be in our situation. So it's just sort of a heads up that these patients are likely to be in the wrong plan at that 4-day visit and will need to get moved. What you need to do in this situation is, and the guidance from Mass Health is that these bills for those visits when the child is in the wrong plan are just to be sent to the plan of record at all times. These plans are supposed to be honoring those visits as part of continuity of care and newborn care, et cetera. So they shouldn't get denied. What I can say to be transparent with you is that it's been inconsistent at best as to whether or not these bills in those situations are getting paid or not paid. Leah could probably go into the specifics about which plans are better about it than others, more so than I could at this time. But the good thing is that there's a lot of activity going on to improve this going forward. And some of that's happening starting in 2020, which is in the next slide. So the notice of birth form and process is evolving to make it easier for patients for this to get completed. It's eventually going to be digital. They'll be easier for them to identify a plan when it's getting filled out, et cetera. The big thing that's coming up is in the newest contracts. What is going to happen is that newborn care, wild child visits, all the things that fall into this bucket are going to be covered regardless of PCP affiliation for the first 30 days of life, which means any contract in the ACO environment is going to pay for any kid under 30 days old for their care. So that should allow a very generous window for any of these kids to get switched onto the correct plan and get seen for those, that 4-day visit, that 1-week visit, et cetera. Another thing we're working on is getting kids assigned to their siblings plan instead of mom's plan from an auto assignment process. It seems far more likely that you're going to be seeing the same pediatrician or same physician as your brother or sister than you are necessarily your mother or practice for that matter. So that's something we've been advocating for, and that is hopefully coming through in 2020 as well. And then ultimately, sort of our best case scenario, it will be almost more than a year away. But this is to say that newborns, instead of being defaulted into a plan or auto-assigned into a plan, they're going to go to fee-for-service for the first some period of time. That period of time has not been finalized. We're pushing for 45 days. And that fee-for-service will mean there's no more of this question about them in a wrong plan, we have to move a plan, whatever. It's just that they're going to be in fee-for-service until they take action to select the plan. And if at the end of that 45 days, the family has not selected a plan for the child, then they will go into sort of this auto assignment process where they would get switched to a siblings plan or a mom's plan or whatever the case may be. So the good thing is, like I said, is that this has been an ongoing area of advocacy from our pediatric ACO this whole time, and we've worked out a lot of the kinks, and some of the benefits of that process are going to be in place as you're joining the team. So hopefully the pain points will be fewer and smaller for you all. Leah, am I missing anything, or is there any other big takeaways we need to cover there?
No, that sounds great. The only thing I would add to that is if you do see a newborn, for a 2-day, 4-day, and they're not yet in our plan, if you have claims issues, let us know. In some cases, we can work with the other payers to get those processed. As Dan had mentioned, we're more successful with than others. But for instance, BMC's been really great to work with. We've been able to help with that. And then if it's any other Tufts plan, those ones are pretty easy for us to help with as well. The Partners plan and there's a plan out in Western Mass that are less easy for us, so that won't be as big of a problem for you. But let us know if you're having these claims issues, and we will try to see what we can do to help with that. Great. So continuity of care for the first 90 days when these patients are moved into the Tufts Boston Children ACO, they should be covered by a 90-day period of continuity of care. After that time, we have an escalation approach for you, as you can see on the slide. So typically the best method is to reach out to provider services first to see if they can help. If they're not able to help with whatever the issue may be, typically the continuity of care covers things like prior authorizations and medications and things like that. If you have difficulty after the COC period's over and provider services is not able to help you with that, then you can definitely escalate it up to this ACO email, and they have contacts over at Tufts that can help us with this. In the bottom, it tells you some of the information that we'll need in order to be able to escalate it. So it's important that we know when you spoke to provider services. That's something, depending on the information that they're giving you, that we can look into further with management at Tufts. Your contact information is important, of course, so we can get back to you. And then including the patient's information is really helpful, because that's how we'll work with the payers to get the issue resolved. Now, the ACO info email address is a Monday through Friday type of contact. That's not for urgent after hours issues. We don't expect that you'll see a ton of issues fall into this bucket. Last year, we didn't have a big problem with this, but we did want to provide you with an escalation path in the case that you did. Great. So the long-term services and support program, Dan, can you speak to this a little bit? If not, it's...
Sorry, I was unmuted. So the BCH ACO is contracted with all the providers in the LTSS program, and we're currently working with MassHealth to get a list of the patients that are currently enrolled in your LTSS program for your existing ACO. The reality is not much will change for these patients, and it won't really change anything you're doing, because they'll still be able to work with the same providers. It's just that their insurance plan card is changing, and you know, and who's getting notified of that care plan, et cetera, is changing. So it's Tufts now instead of Nicola or Stewart or whatever the case may be. So it really should be very, very, very low impact. I guess the reality is we're still working out the details of if there is any meaningful transition that needs to happen in this scenario. And once we understand that better, we'll certainly be looping back to all of you. I think that's an area maybe we'll touch on in one of our future webinars. But the good thing is, because we're fully contracted with all of the providers in this program, there should be no gaps, and it should be a very smooth transition ultimately.
Thank you.
Yep.
So one of the items that we have implemented across the PPOC based on the ACO requirements is a health needs assessment. Right now, because you're not on Epic, this is not necessarily meaningful for you. Once you get onto Epic, you'll work with your practice consultant to determine what's the best way to roll this out. Many practices are doing it for all of their well child visits. It is recommended by the PPOC that every patient have a health needs assessment annually. And there are some webinars that are available you'll have access to once you start to get set up with Epic. You'll see that we have a learning management system with recordings and training. So once you start to get access to those, then you'll be able to get in there and see the training that is specific for the health needs assessment and also for creating a care plan. This program falls under our medical home support team. And so we do have a real-time support program that you can contact once you start doing needs assessments and care plans at the email and telephone number listed here. And again, this is something that you'll hear a little bit about when you're doing your onboarding. So for those of you who have onboarding come up, we'll talk about this a little bit more with the MHCC team and also your practice consultant. And I wanted to invite you to our September 20th practice manager meeting. That's actually Friday. It is available remotely via Zoom, similar to this meeting. This week, we're going to talk about a new learning management system, actually. We're transitioning over, so for you, it will be new regardless. But I'll also talk about some payer updates and things like that. These practice manager meetings are held quarterly, and they you can either attend on site at Waltham, sometimes Bridgewater or Northampton, or you can attend remotely. We also have our next practice manager learning community coming up. The topic will not necessarily be relevant for you yet because it's very much EPIC related. October 9th, one of our local vendors is offering a free program for our practices to learn about building your dream practice, and that's in the case that you need to do any renovations or if you're looking to open a new site or move your site. So that is coming up October 9th. It's intended for practice administrators and or physician leaders. It's free to you. There will be refreshments, food and drinks available. If you did want to register, you can just email me and I can add you to the list. And then the December quarterly practice manager meeting is coming up on the 11th of December. I do not have a topic for that one yet, but when I do, I will communicate that out via our weekly roundup. Now, the remainder of this presentation, which I'm going to send out via email, is really an appendix of different instructions. How do you run a Tufts public roster? How do you update a patient's PCP? How do you change a patient's plan? So I will not spend this webinar going through this, but I will send these presentations out to you. And if you have any questions about any of these workflows or how to get access, definitely reach out to me. I'm more than happy to walk through with somebody on your team on how to do some of this. Now, with that said, I do not have any other agenda items that I need to address. So for those of you out at the practices, do you have any specific questions that we can talk about now while we have a few minutes left?
Hi, it's Woburn.
Hi, Woburn.
Jillian has a couple of questions.
Okay.
I just wondering, are there any supports already in place in regards to ACO team for like care manager and community support worker?
Yes.
For those.
Yeah, the PPOC does have a care coordination team here, and we have regional support teams that will be available for your practice. And that's actually something that we will review when we come out next week and do your onboarding. I think we're there on Wednesday, if I remember correctly.
Excellent. Thank you, Leah.
You're very welcome. Any other questions? Great. Okay, well, thank you again for joining. I hope that this was helpful. And as I mentioned in the beginning, you know, it will not be our last webinar with you. This is really just a general overview to let you know, that we're thinking about these different areas and we're putting, methods in place to support you through the transition. This is our third time doing it, and I feel like we've kind of worked out many of the kinks. So fortunately for you, we are expecting things to go pretty smoothly as they can when, third-party payers are involved. So again, reach out if you have any questions. I will send out these slides to you. You can share them with your team and let me know if anything comes up in the meantime.
Thank you.
Thank you. Have a great day.
Thank you. Bye-bye.
Bye, Dan. Thanks for your help.